Hey, new nurse, can I walk you through how to become a great long-term care nurse while keeping your sanity, loving on your patients, and keeping your job and your license? Hey, my name is Nurse Key. I've been a nurse for 6 years, started as an LPN and now I'm RN in NP school. I worked in long-term care, worked in multiple units, but I just really want to help long-term care nurses. Long-term care nursing is not what people think. Instead of taking care of just someone's grandma or grandparents, there are more young people in nursing homes and skilled facilities than ever before. So let's go over it. Okay, so let's start from the beginning. Long-term care or skilled nursing facilities, they have patients that generally have chronic disorders and they cannot assist themselves in two or more activities of daily living, which would be toileting, hygiene, feeding, mobility, dressing, showering, things of that nature. Now, in long-term care as a nurse, yes, you may have orientation, but it could be as short as 2 weeks. And the type of orientation you may get, it could be hit or miss. So it's important that you kind of take initiative to learn on your own and to really be diligent about learning your patients, their disorders, and the medications that you're given. All right, so like I said, orientation can be 2 days to 2 weeks. In reality, long-term care ratios can range anywhere from 1 nurse to 20 to about 40 patients, depending on which state you are in. So that means that as a nurse, your duties not only include, technically we house all of the CNA responsibilities plus medication administration, wound care or treatments. We have to make sure about nutrition. We have to make sure of repositioning every 2 hours if that person is unable to reposition themselves. We have to worry about incontinence care, and then also we'll look at their tubes, and if they have a status change, we'll have to escalate that for any emergency or urgent treatments that may be needed. So in orientation, generally you're going to learn about the facilities policies, you'll learn where the crash cart is, you'll learn who is the physician teams and how does their on-call schedule work, documentation basics, where is the medication stored, narcotics, and any stock medications, is that on the cart or is that in a room? You'll learn other wound care routines, or is there a wound care nurse on the unit and what days they may show up. You'll learn of any emergency procedures, and if the patients have a status change, how do you handle that? Any facility layout and workflows, and then what is your ratios? All right, so common conditions to know in long-term care would be, of course, dementia or Alzheimer's, right? That would be like mental or cognitive decline. That person could be confused, but sometimes it comes and goes. Hypertension for high blood pressure. Of course, if you'll start to recognize medications for hypertension, you'll know, hey, I need to check the blood pressure before giving this medicine, and then I might need to reassess afterwards, right? Then diabetes, you'll learn, okay, if this person's a diabetic, you'll get that in report. I need to do blood sugars about 3 times a shift before breakfast, lunch, and dinner, and then reassess to see if they're having any symptoms. CHF, you might look for edema, you might look for blood pressure, you may look for fluid overload, fluid intake, eye, nose, and urine output. COPD, do they have any inhalers? Are they on oxygen? If they're on oxygen, right, we're not going to have the oxygen above 4 liters if it's not ordered. And then we'll check the post-ox periodically during the shift to make sure that's greater than 88% as ordered. Stroke history, okay, so when you have a stroke patient, all right, you're going to look at their swallow. Are they NPO? How do they move? What is their mobility? Are they able to reposition themselves? Do they have proper sensation bilaterally on both sides of the body? And then also blood pressure as well, and then look at their medicines. Parkinson's, do they have rigidity? Do they have tremors? How is their mobility? How is their incontinence or continence function? Chronic kidney disease, do they have dialysis? And if they do, on which days? Do they have an AV graft or a fistula? Does it have a bruit or a thrill? You'll have to document that, so things to just know. Also, for chronic kidney disease, their eye, nose, are they on fluid restrictions? Do they have to have certain medications such as diuretics? Do they make urine, or are they anuric or oliguric? Osteoarthritis, do they have to take medication for inflammation? Does that affect their function level or mobility, and to what extent? And depression, anxiety, do they take medication for that? Do you have to monitor them like psych monitoring, or is there any special parameters for that? So generally, those are just some common conditions that may be present in skilled facilities, but of course, there are plenty more. Now, medications to recognize, we'll look at antihypertensives, cardiac medicines, metoprolol, amlodipine, lisinopril, furosemide, diuretics, or water pills. You'll need to know what vital signs to monitor for this. What is their baseline? Fluid intake, urine output. Diabetes, like metformin or insulin. Remember how to give insulin and what syringe you need to draw it up. Generally, it's the orange cap syringe, and it is in units, not milliliters for insulin, right? Just key things to keep in mind as you're going through your day. Metformin, sometimes it makes them have bad diarrhea or constipation, so the patient may want to refuse it. You may have neural or psych medicines like donazepam, which is for dementia, or Aricept, and it affects how people think. Namenda, which is another dementia medication. Seroquel for depression or anxiety. Trazodone or Zoloft for depression. Trazodone for sleeping or sometimes anxiety, but it is like a little sedative, so you'll notice what time of the day you'll be given that, closer to bedtime. Pain medicine, of course, you assess pain and then reassess it within 15-30 minutes, depending on your facility's protocol. Tylenol, tramadol. Tramadol is a narcotic, right? Gabapentin can be a narcotic at times too, so you may have to count these. Stool softeners, laxatives, proton inhibitors. These are all GI medications. So stool softeners, laxative. Okay, are they incontinent or continent? Are they going to tell you if they have a bowel movement? And then proton inhibitors to reduce the acid in their stomach. So in long-term care, these patients can have up to 20 to 30 medicines at one time. So it's easier if you already understand what medicine you're looking at. So when you pull it, it just makes it easier to pass, and they can tell them, okay, you have this, this, and this that I'm giving you, and it's for this. It helps you run through it. So becoming more aware of your medicines, it helps you prepare in the long run. And so I actually made a tool. If you click the link in my bio, I actually made the top 100 medicines that a new nurse actually needs to learn, and it's flashcards. I have it available as a PDF. So if you click the link in my bio, it's the new nurse medication flashcards. All right, stay tuned for part 2. Hey, are you a new nurse working in long-term care? Well, this is part 2 of the orientation that you deserve. So if you missed part 1, go ahead and check it out, but let me just tell you what we went over. In part 1, we talked about the orientation timeline, 2 days to 2 weeks, right? Realistically, and some common conditions and medications you need to know while working with long-term care patients. All right, so part 2, we're going to break down wound care. Wound care is such a buzzword, big topic, big incidents that happens in long-term care, but not on our watch, right? So you're going to learn, how does it happen, how can we prevent it, and how to do wound care, right? So wound care, bed sores, pressure injuries, these are interchangeable, right? So wounds, let's talk about like how we prevent wounds, right? Let's start there. So let's say you get a patient, they're admitted, they have perfect skin, which is intact, warm, and dry, no open skin issues, no skin concerns. So with that person, even if they're let's say they're not mobile, they need assistance with repositioning, you're going to turn them every 2 hours. So let's talk about turns. When a person is turned, that means to shift their body weight off of one side onto the other side. So generally, most facilities now have a left or right policy, which left or right means you are going to turn that person from a supine position, right? So we know that person is laying flat. Back is flat on the bed, to a left position or a right position, right? Either way, that means all of their weight has to be on that side. The butt is off of the bed. The heels are off of the bed. The back of the head is off of the bed. So that constitutes a full turn. Now, most patients, if they have to be turned like that, they cannot hold their own body weight, so you have to support them with pillows or wedges, or maybe a little bit of both depending on the weight and then how you turn them. So support them, so turn them fully onto one side, support them with pillows underneath the head, underneath the back, and underneath the it's kind of like the butt, but the butt has to be floated up. So it's kind of like underneath the thighs, and then make sure the heels are off the bed as well. So you need about 4 pillows or wedges to really get a person off of their side, and then every 2 hours you'll rotate left, right, left, right. All right, so that's one. Repositioning is a big thing. Then we're going to talk about hygiene. So you could turn a patient, but if they have skin breakdown from incontinence and being soiled for so long, the longer moisture sits on skin, the more likely the skin will break down. So not only do they have to make sure that they're clean, dry, so incontinence care every 2 hours, but then we can also apply barrier cream to those areas to make sure skin doesn't erode and not open up. All right, so repositioning, hygiene, and incontinence care if they're incontinent, and then nutrition. Because you could do all the things, but if their skin is already frail, and we know as you age, skin will break down, especially if you're not eating enough protein. Is more susceptible for skin breakdown. So nutrition will look like protein. Some facilities, they'll order ProSource or extra protein supplements, or even Juven, which is like for wound healing and extra calories, or you have Boost, or not Renvela, but it's the other one, renal support. So these hand in hand, these are actually like the building blocks for good skin hygiene. Repositioning, hygiene and incontinence care, and then nutrition on a cycle of every 2 hours. It leads to perfect skin. All right, so that's for prevention. Now let's say if your person already has wounds or they came into the facility with wounds, you're still going to do all those things, right? But we already have a problem. Let's talk about some hot spots of where to check on your patient for possible wounds. All right, so starting with the obvious, the sacrum, right? This is the general place that we think of for bed sores or pressure injuries. The sacrum could be also known as your tailbone area, where your backside rests on the bed and creates pressure. Some other areas could be the back of your ears, the back of your head, both elbows, and your heels. Those are general overlooked. So when you get a new patient, or even on your shift when you're doing your head to toe assessment, make sure that you're looking behind these places. Look at the heels, take those socks off, press the heel, see if it's blanchable. If not, go ahead and escalate it, see if it's been documented, and if it hasn't, put in a wound care consult. Now with more skinnier patients or patients prone for pressure injuries or more susceptible, we'll go ahead and put a Mepalex or bordered pressure dressing on these areas. Generally, we like to have the Mepalex on the sacrum, right? But if you know that they're already at more risk for skin breakdown, go ahead and put on their heels, possibly their ankles, and sometimes their elbows, and sometimes even on their hips, just depending on how skinny or thin that person may be. So now we're going to add on wound care and body alignment. So a lot of times I'll go in patient's room and I'll see these patients are not only contracted, but they're laying pretty bad. So when people are in bed or even in the wheelchair, you have to make sure the body is aligned properly, right? We learned this in anatomy and physiology. So the body should be upright in a right position. Head should be backed, not cocked back forward or laid back, because if you think about it, if a person cannot reposition themselves or move, they're going to stay in whatever position you put them in. So with the head, I always see people's head not supported by a pillow, so it's leaning back forward. You have to make sure the pillow is so their head has a little space between the chest and the chin. It's midline and it's supported. And then also with the hands, it's a big one. You want to make sure people's hands are not contracted closed. So sometimes we'll fold up a towel and put that in there just to have so they have some space in between that. And then feet, you want to make sure the feet are not what we call foot drop. You can put the heels, the Prevlon boots onto the patient's feet, and it supports the foot to be up at the proper angle and supports the ankle, or else it'll be slight and then it'll be stuck like that. So if they do get up and walk, now they have to work on mobility and foot positioning. All right, so that's body alignment. We talked about contractures, now wound care. Wound care, so with repositioning, so with the wounds, I used to do wound care as well. You'll have to follow the facility's protocol for wound care, so I don't have to go into too much of the treatments, but what I will say is, with wound care, let's say you have a new admission or a new wound, let's say a skin tear, a pressure injury. If it's a new injury, just go ahead and do a wound care consult. Make sure that you are able to dry the wound, clean it if it's bleeding, or if there's any discharge, clean it with, let's say, even normal saline and gauze, and then cover it and just protect that it's covered. And if it needs to be have a little barrier, you can put the bordered pressure dressing just to make sure it has a little barrier between friction, or if that person has to be positioned on that side. Now with wound care, we learned in nursing school, is there's different stages of a wound. Some facilities will allow you to stage them and some will not, but if you are allowed to, just for reference, stage 1 is non-blanchable redness. So if the skin is how we blanch fingertips, if you press on that site and it does not turn white, it continues to stay red, that's unblanchable. Stage 2 is now the skin is actually open in that area. Stage 3 is where you can start to see fat and you see up underneath. So it's like the deeper that it goes. And then stage 4 is down to the muscle and down to the bone. And then, of course, there's some that are unstageable because it has like the black scar around it and it needs to be debrided to actually see how deep that wound is and if it tunnels. So those are different stages of wounds. But the basic one is if it's an injury, doesn't matter if it's a skin tear, which older people are more susceptible to, or if it's a pressure injury or anything in between. Document, document, document. Escalate it, do wound care consult, let the charge nurse know, let the DON know, or whatever your facility's policies will be, but report it. Document that you reported it and follow up and say what the treatment or the intervention was. Cover yourself at all times. All right, so I'll see you for part 3 of the long-term care orientation for new nurses. Hey, long-term care nurse, and welcome to the orientation every long-term care nurse deserves. My name is Nurse Key. I've been a nurse for the past 6 years. Started off as an LPN working in long-term care. I'm an RN, and now I'm in NP school. All right, so this is part 3 for the new long-term care nurse orientation. So we're going to talk about a day in the life as a long-term care, and we're going to talk about the nursing rounds. Okay, let's get started. If you haven't checked out part 1 and 2, go ahead and watch it. It's on my page. We went over good things. Now part 3, a day in the life. So let's use it for example, right? What were you doing? 17. Breathing. Forward, breathing. Go sleep. Make sure there's no balances for today. No doctor's appointments. I can get that listed. My blood sugars are getting ready. 38. If you're going to go get vitals, we're getting patients up, we're getting hygiene, we're getting cleaned up for the day, and loads are being given. Breakfast should be on the floor. Now I just have a medicine mess. All the patients eating breakfast. I can see their swallow. I see how they're handling or the mobility wise, and they have fullness from my mindset. So that's from 10 to 11. I'm gonna try to catch my breath before lunch is again, and then lunch will be coming up again. So we clear the trays. Now 12:02. It's now 11 minutes to pass. I'm eating lunch. We're doing our rounds, make sure everybody's changed. Everybody's turned, everybody's clean, happy, and fed. From 2 to about 4 p.m. It's gonna be what also take out lunch and give blood sugars before dinner. And then minutes advance and hey, are you a new long-term care nurse? This is the new nurse orientation that you deserve to be the best possible nurse you can be. Hey, my name is Nurse Key. I've been a nurse for 6 years. I transitioned from an LPN to an RN, and now I'm in NP school. Starting off in long-term care was no joke. And this is the orientation I wish I had as a new nurse. So this is actually part 4. Check out the other 3 parts that I've already recorded. They're on my page. Part 4, we're going to go over the long-term care nurse handoff report. So receiving handoff, there are a few things that you have to know to give safe care, right, for your patient. Now, starting with your report sheet, the ratios in long-term care, of course, are high. You can have anywhere from 20 to 40 patients. So if you don't have a report sheet with your facility, just get a blank piece of paper. Remember from like kindergarten, you do hamburger versus hot dog, and then you fold your paper how many times, however many times, based on how many patients you have. So each patient will have like a little square, right, at the end of it. All right, so once you have your report sheet, some people have fancy ones. I use a blank sheet of paper and I get to it. Doesn't matter. It's the information that is most important. So for every patient, there are a few things that you need to know. Demographics, of course, you need to know their name, how old they are, gender, right, to see what their preference is or what name they want to be called. Code status is a big one. Is it full code? Is it do not resuscitate? Does it do not intubate? Know that almost more than you know their name. What is their admitting diagnosis? Why are they here? What are they complaining of? What is their medical history? And then, all right, so then we'll talk about like the body systems. Now, trying to get handoff is going to be different long-term care versus in the hospital as to what factors are reported. We're going to look at neural. Are they alert and oriented ×4, or what is their orientation status? We're going to ask, how do they take their meds? Do they take it crushed? Do they take it whole? Or are they NPO? Do they take it by their PEG tube or only by IV? It's always necessary to know. And what is their preference? Pudding, applesauce, or in a liquid? Are they known to refuse medicines? Do they spit it out? Those are the things that you give in handoff. Continence is a big one. Continent of bowel and bladder, right? Continence basically means, are they able to sense that they have to eliminate, whether by urine or stool? Do they have that sensation? Are they able to tell you and they feel it? When they feel it, are they able to tell you? That's continence. Are they continent or incontinent bowel bladder, or do they have a Foley or ostomy? Those are good to know. And then tubes. Do they have any sort of tube, whether it's peripheral, IV, PICC lines, central lines, PEG tubes? Do they have supplemental oxygen, BiPAP, or CPAP? Always like to take note of those. Skin and wounds. Do they have any open wounds on their skin, or is it warm, dry, and intact? If they do have skins, is it already documented, and is there a treatment plan in place, and where are the treatment supplies? Generally they're in a treatment cart, but just in case they're not, are they in their room, or where are they located, or they're on back order with pharmacy? Mobility. How does this person get around the unit? Are they total care where they need full assistance by the staff? Are they fully ambulatory independently? Do they use a cane, walker, or a wheelchair? That's always good to know. And then any pending appointments, whether it's dialysis, a doctor's appointment, or a family visit, you'll need to know what they have scheduled for that day, because it affects your plan of care for the shift. So I hope that helps. That was a little quick synopsis of how to do a handoff report for long-term care. Next, we're going to talk about rounds. What does nursing rounds look like in long-term care, and what is important?